I'm the National Manager of Support Services at the American Liver Foundation. And for those of you who may not know the founding, the purpose, the American Liver Foundation is the nation's largest nonprofit serving people who have liver disease. We provide a voice and an ear for patients with liver disease and for their families and caregivers. And we do this through research, advocacy, support, and education, which is what we're doing here today. I want to welcome you to basically what's a new year of our Ask the Expert series. We developed this long-running series because we heard and we continue to hear from so many people who say they either forgot to ask their doctor a question during their appointment, or that they realized on the way home, even in the car, that there's something that they didn't quite understand or something that didn't make sense to them, but by that point it's too late. So we thought it would be helpful if we brought in medical experts so people can ask some of those questions or help them to understand some aspects of their disease or of their treatment plan. I always preface our discussions such as this by saying that our guest today is not our personal physician, but I always say perhaps by the end we'll wish he was. So he may not be able to speak to your exact situation, certainly would not be able to tell you what to do because only your own healthcare team can do that. But hopefully all of us will get a better understanding of the latest information and research regarding PBC during our time together today. During this session, we encourage all of you to write your questions in that Q&A section. Now, you'll see that option on the bottom of your screen. Don't put it into chat because we won't see that, but put it into the Q&A section. And don't wait till the end because we don't want to run out of time before having the opportunity to get your question out there. Some of you already submitted some questions when you registered, and I have those here. So I'll be raising those with the doctor as well. And so before we begin, we always like to acknowledge our sponsors. And for our presentation today, we want to thank CymaBay Therapeutics and Intercept Pharmaceuticals for their support of our program. So our presenter today, we just heard that he's in Chicago, a very cold and snowy Chicago, but Dr. Gautham Reddy is from the University of Chicago School of Medicine. Dr. Reddy specializes in diseases of the liver and is the director of the Transplant Hepatology Fellowship Program. Now, in easier terms, what this means is that Dr. Reddy teaches doctors about liver disease. And we always find that the doctors who are teachers present information in a way that's understandable and in using the latest research available. So Dr. Reddy, thank you very much for joining us today.
Thank you so much for having me.
Yeah. Great. So here we are now, the year 2022. So as I said, this is our first Ask the Experts program in this new year. And so 2022, what's happening in the area of PBC that all of us should know about? I know you're going to give us a great presentation, but we'll just jump off and get right into that question.
Well, I think there is a lot of excitement about things that are coming down the pike as potential future treatments. I suspect that this is a pretty mixed crowd of patients, some who've had PBC for a long time, who are super well informed and know a lot already, and some that are newly diagnosed and maybe exploring more about their disease. As you said, I won't be able to answer everyone's question, but I'm hoping this talk has a little bit of something for everyone, so they can improve their own knowledge of their and understanding of their disease, of the disease of their loved one. Okay, so with that, I'm gonna jump off here. Thank you once again to the ALF for having me, inviting me to give this talk. Let's see here. So just my potential conflicts, I do a lot of clinical trial work, and I'm involved with multiple companies at the moment. I am employed by the University of Chicago, so none of the money comes directly to me. It's all payments to the university. I do want to point out that CymaBay is sponsoring or a partial sponsor of this program, and I am doing work with their company. I will be discussing some off-label treatments for PBC and some off-label treatments for PBC-related symptoms. So what we're going to be covering today, we're going to define and diagnose PBC, talk about management of PBC and management of PBC symptoms, some about complications of PBC, as well as some clinical trial information that many of you may find helpful. So to jump into defining and diagnosing PBC, what is PBC? So PBC is a chronic cholestatic liver disease. And what cholestasis simply means is it's a disruption of bile flow. Now that can be anything from a gallstone blocking a bile duct, or it can be an inflammatory process such as PBC. And what happens in PBC is the immune system attacks the bile ducts. The hallmark of this is a positive antimitochondrial antibody, or AMA. It has a predilection for women. It's actually pretty uncommon. The prevalence is estimated to be about 290 cases per million people in the United States. So if you do some back of the envelope math, that's about 95,000 people in the United States are estimated to have PBC. The median age of diagnosis is 55, and it's associated with a bunch of different autoimmune disorders, things like Hashimoto's thyroiditis, Sjogren's, rheumatoid arthritis, celiac disease. Because even if you have PBC, though, it doesn't mean that you will develop other autoimmune disorders. It's just something we need to be aware of and think about over time. This is a really complicated cartoon that even bamboozles my fellows and students. And I promise I'm not going to go too into detail here, but what you have here is a nice, healthy-looking bile duct here in green, and then liver cells, hepatocytes. So there's really two main subunits of the liver. The hepatocytes will sort of do most of the functioning of the liver, and the cholangiocytes are the bile duct cells, which kind of drain the liver, and it forms these little tubes. And what happens, at a 40,000-foot view is, at some point, people who have a genetic predisposition and lose tolerance to certain likely infections, so it could be a virus or a bacteria that has similar DNA to a certain subunit of the so-called mitochondria of the biliary cell, of the bile duct cell. And so what happens there is you lose tolerance to this and develop these antimitochondrial antibodies. And these antimitochondrial antibodies will trigger inflammation in the bile duct. So it'll cause inflammation and will recruit these hepatic stellate cells, and in some cases can cause fibrosis. And fibrosis is just a fancy term for scarring on the liver. And over time, if it goes unchecked, it can lead to cirrhosis and complications of cirrhosis. This concept is called molecular mimicry. So features of PBC presentation, about half the patients who we diagnose with PBC are asymptomatic. Fatigue seems to be the most common symptom. It can be a really terrible symptom. Pruritus is another, is a fancy way of saying itching. It can also be a vexing, a really vexing symptom. Over time, it can cause enlarged liver or spleen and advanced disease, yellowing in the skin called jaundice from elevated bilirubin. Other symptoms, we'll talk more about sicca, which is dry eyes, dry mouth. Some patients have restless leg, insomnia, depression, some cognitive memory issues. So how do we diagnose it? So we suspect PBC in someone who has an elevated alkaline phosphatase. Now you'll hear me talk about ALK phos a lot during this talk. It really is something that's important that we follow. And ALK Phos is simply a blood test that we get in a normal liver chemistry panel. It's part of a comprehensive metabolic profile that we frequently order in patients in primary care clinic. And often we'll see someone that has an elevated ALP, and they'll get sent to us and we'll diagnose them with PBC. Now, part of this ALP is certainly not specific for PBC. There's lots of things that can cause elevated alkaline phosphatase. We generally want to rule out any kind of bile duct obstruction. We use a physical exam and imaging like an ultrasound or an MRI of the bile ducts. We also want to exclude medications and other causes of cholestasis with a very careful history taking. But to make the diagnosis, you need two of the following three. You need biochemical evidence of cholestasis based on an elevated alkaline phosphatase, along with a positive antimitochondrial antibody, or there's some other PBC-specific autoantibodies that we can check as well. Now, 5 to 10% of patients with PBC may have AMA-negative PBC. We will sometimes often also do a liver biopsy. And so if two of those three are consistent with PBC, we diagnose PBC. Now, there's a lot of questions about AMA positivity. There are a lot of people walking around with an AMA that's positive that don't have PBC. If we see patients like that, we generally follow liver tests yearly. So when do we biopsy for PBC? Well, if the PBC antibody, the AMA, is negative, we'll biopsy. If we're curious if the patient may have coexisting liver disease, maybe they have fatty liver, patients who are overweight with diabetes, who have elevated liver tests, and we may want to try to separate out what's PBC and what's maybe NASH, we do a biopsy. And we'll talk a little bit more about AIH, which is autoimmune hepatitis, patients that have elevated AST or ALT that are, 5 or 6 times the upper limit of normal, we may do a biopsy because the treatment is different. Patients who have unexplained cholestasis, and we want to rule out other things like drug-induced liver injury, sarcoid, we may do a biopsy. Now, along the bottom panel here, you can see a bile duct here. And this is a really inflamed bile duct. You can see a lot of blue inflammatory cells around it, lymphocytes. And this is called lymphocytic cholangitis or a flora duct lesion. This is sort of the classic look. And over time, it's a little hard to see here, but there's a lot of missing bile ducts here. Here you can see a bile duct with a lot of little inflammation a little bit further away. This is called interface hepatitis. I will bring this concept up more. This may also make you think about a concomitant autoimmune hepatitis with PBC. If PBC progresses, particularly if it's untreated, it may lead to cirrhosis. Here you can see areas of hepatocytes here, and then surrounded by scarring or fibrosis of the liver and nodules. This is a biopsy of a patient with cirrhosis. So jumping into management. So it's important to understand that management of patients with PBC needs structured and individualized patient-centered care. I do highlight that this does require lifelong care. It is a diagnosis that we generally can manage, but it does require the patient to come and see us and make sure they're staying in contact with us. But the goal of treatment is to prevent end-stage complications like cirrhosis, but also, importantly, to manage the associated symptoms that affect quality of life, like itching or fatigue. Now, I think many of you know the sort of cornerstone of our treatment is ursodeoxycholic acid, or URSO. It is a first-line treatment. We generally want to dose it somewhere around 13 to 15 milligrams per kilogram daily. I will often start with about half the dose and then slowly increase it up to a full dose over a couple of weeks. Now, it can be taken daily to encourage compliance with taking it, or it can be split up to a couple of times a day. But the idea is that it promotes choleresis, and that's just a fancy way of saying that it improves bile flow. It also stimulates the cholangiocyte, the bile duct cells, to secrete bicarbonate, which actually protect those cells against some of the really bad and harmful bile acids, so-called hydrophobic bile acids. About 40% of patients are inadequate responders, meaning their alkaline phosphatase doesn't drop far enough, and we'll talk more about that. And 5 to 10% of patients may be intolerant of urso, generally around diarrhea or hair thinning. Um, Urso, unfortunately, doesn't help some of the symptoms like fatigue or pruritus, but there is a significant survival benefit. And this is really data that was gathered from patients who were started on Urso early on, the 80s and 90s. And actually, the survival benefit's probably better now, but you can see the 5, 10, 15 years using Urso versus no treatment, the survival is significantly higher. It's important that we measure alkaline phosphatase after at least 1 year. We generally do it before that, but that gives us an idea of how to prognosticate how a patient is doing. Now, this is sort of a busy slide, and I took this from some of the guidelines, and this was actually from the European version of the of a liver society in Europe. We have the counterpart here in the U.S. called the ASLD. The European is called EASL. Now, there's sort of 3 buckets here, and we want to stratify, risk, and treat. So a patient that has PBC, we start them on Urso, and we assess their response at 1 year. We do that by looking at alkaline phosphatase. So a responder has what we consider low-risk disease. We continue to follow them. We continue on Urso. An inadequate responder, we want to look and see why. Is this someone that we think has autoimmune hepatitis, or their AST and ALT really elevated? Do we need to sort of progress with treatment? There is a medication that's relatively new to the market, obeticholic acid, or Ocaliva. I will call it OCA for short. Now, this is a drug that came out, I think, 2016. And it's one that is helpful to improve response to Urso. It's an add-on medication. From then, we can do some off-label things, which I'll discuss, as well as potential for clinical trials. We continue to monitor patients with labs and something called elastography, which is an ultrasound way of measuring liver stiffness. Now, patients, when we diagnose them, we want to know if they have cirrhosis. We look at blood work, we look at ultrasound imaging, and we measure their stiffness with elastography. If the patient has elevated bilirubin, or they have evidence of end-stage liver disease, such as fluid in their belly called ascites, or they have variceal bleeding, we want to get those patients over to a transplant center and see someone like me relatively quickly. Patients who may have cirrhosis but don't have complications, we can generally be followed with just screening for liver cancer and varices, and we'll talk about that. And then actively, we want to talk about symptom management, and we'll go through some of that here. Now, the risk of progression is largely defined by the Urso response. Now, patients who start Urso and they can drop their alkaline phosphatase to less than 1.5 times the upper limit of normal. Now, in my lab, the upper limit of normal for alkaline phosphatase is 120. So 1.5 times that would be 180. So in my lab, if someone's Urso responds down to, if someone's PBC responds to Urso and their alkaline phos is less than 180, their bilirubin is normal, their risk of progression is pretty low. It's actually their life really is no different than someone that doesn't have PBC. Now, the FDA, the Food and Drug Administration, has a slightly different definition to get medications on the market, and their response is an alkaline phosphatase less than 1.67 times the upper limit of normal, which is around 200, a normal bilirubin, and a drop in ALP of at least 15%. There's you can really go down a rabbit hole thinking about classifications. I mean, a lot of these rules the FDA uses are based on some of these classification schemes. What's more, I think, clinically relevant are the Globe and UK PBC scores, which can really be a good measure of individual risks of progression, and we'll talk about that. There's some other predictors of progression. Patients who have PBC diagnosed at an earlier age, less than 45, are more likely to progress. someone who you diagnose with cirrhosis or near cirrhosis is more likely to progress. Men have a higher risk of progression. We talked about liver stiffness and FibroScan, which is becoming more and more available. If that level is over 9.6, patients seem to have a higher risk to progress. What's probably more important than a single measure is measuring stiffness over time. There are some new blood tests, the so-called ELF test, which is a combination of biomarkers that we can measure in the blood. This has just become FDA approved, and you may see that being used more in the coming years. Now, risk scores, and so these are two different risk scores, the GLOBE score and the UK PBC score. These define, again, individual risk of PBC complications after 1 year or so. These are complex formulas, but there are calculators available online. I've listed the websites for both. The GLOBE score gives us 3, 5, and 10, 15-year transplant-free survival rates. This is validated. The UK PBC score gives us a risk of liver transplant or a liver-related death at 5, 10, or 15 years, and these use widely available parameters that we check routinely at clinic visits. So this is something that I really use a lot in clinic, and it helps me tell my patients what the risk of progression is and should we consider other treatments besides URSO. So second-line treatments, we talked about, I mentioned it, obeticholic acid or OCA. This is an FXR agonist. It directly regulates genes involved in bile acid synthesis, secretion, transport, and detoxification. Now, this was designed as an add-on for patients who were on URSO but didn't fully respond, so they had an alkaline phosphatase above 200, or they were intolerant. Maybe they had nausea with it, maybe they were losing their hair. But the trial primary endpoints, POISE was the name of the trial, were the same ones that the FDA used. So an alkaline phosphatase less than 1.67, so less than 200, with at least a 15% drop from baseline, as well as a normal bilirubin. And it turns out that nearly half the patients in this clinical trial reached the endpoint versus 10% of placebo. So this this medication is on the market. It's got conditional approval, and it continues to be studied over time to make sure that patients on this will have good long-term outcomes. There are side effects. Itching seems to be a particularly one that's a particular problem. In the study, about 10% of patients dropped out. I will say that this is dose dependent, and if patients at 10 milligrams can't tolerate, often they can tolerate at 5 milligrams, and it does seem to improve over time. There's actually data that says the itching kind of goes down to baseline over time. Patient can also have some lipid derangement, cholesterol issues. It's unknown if this has cardiovascular effects. There are recently some growing recognition that patients who have decompensated cirrhosis should not get this medication. It seems to hasten liver failure. It's a little unclear why. And even in compensated cirrhosis, meaning patients who don't have varices, who don't have ascites, we have to be very careful on how we use it, if at all. Now, there are some off-label medications that can be used in PBC. One called budesonide, which is actually a steroid that gets processed in the liver. It has a lot less systemic side effects than, say, prednisone does, and we use it in things like Crohn's disease or asthma. The data is a little mixed. It probably works better in patients who have a lot of interface hepatitis, which I pointed out on one of the earlier slides. Fibrates is a group. These are a class of medications that are used for cholesterol, the so-called peroxisome proliferator activated receptor agonist, or PPAR agonist. It's a mouthful. These are used again to decrease cholesterol and triglyceride, but it turns out that they also improve alkaline phosphatase, and some itching can get better. There are a lot of studies ongoing. Fenofibrate is a medication available here. It goes under the brand name Tricor. And we've used that some in clinics for people who aren't responding to URSO. Bezafibrate is its European cousin. There's a lot of studies ongoing, and there are some PPAR agonists that are currently in phase 3 trials, which I'll bring up later in the talk. Now, I alluded earlier to this PBC autoimmune hepatitis overlap syndrome. About 10% of PBC patients may have autoimmune hepatitis features. Usually they're AST or ALT, which again, these are labs that are available on the liver panel, are greater than 5 times the upper limit of normal, which is about 100 to 125 in most labs. Their IgG may be elevated. Biopsy really is required to make this diagnosis. These patients will have more interface hepatitis in addition to maybe having florid duct lesions. We tend to use URSO with steroids, prednisone or budesonide. Budesonide has a better side effect profile. Interestingly, the combination of PBC-AH may be better to treat than AIH alone, but you want to consider this diagnosis in patients who are not responding to URSO that have an elevated AST or ALT. Just a brief word about PBC and pregnancy. The recommendations right now are to continue URSO. We think the URSO is definitely safe. There's a lot of data about using URSO in pregnant patients. You may want to consider seeing a maternal fetal medicine specialist and a hepatologist, especially if a patient with PBC and pregnancy is cirrhotic. We do want to screen for these dilated veins or varices in the second trimester. For patients who have a lot of itching, rifampicin has been used and it works quite well in the third trimester. So I'm going to go a little bit deeper into managing PBC symptoms. Fatigue can really be a terrible symptom. Over half the patients that have PBC note they have fatigue. About 20% reported as severe fatigue. It's really unclear. And managing the PBC with URSO or OCA doesn't seem to help. Now, it's really important, and I want everyone to really pay attention to this. I see, we will often see patients who feel like their fatigue is getting worse and they feel like their liver disease is getting worse. I think it's really important to reassure patients that fatigue does not seem to correlate with severity of scarring or fibrosis in the liver. So again, I want to reiterate that point. Fatigue does not mean that your liver disease is getting worse. It is a terrible symptom, but it does not mean that the liver is failing. The most important thing that we can do with fatigue is evaluate for treatable causes, things like anemia, low blood counts, thyroid dysfunction, particularly Hashimoto's thyroiditis, which is an autoimmune thyroid dysfunction that PBC patients get, treatment for and looking for depression. People who have a lot of itching at night are unable to sleep, wake up tired. People who have restless leg syndrome are often tired and fatigued. There are some data for using a medication called modafinil, and this is a drug that's used for narcolepsy, and it can help. But what often helps actually is exercise. Even small amounts can be helpful. And what I generally recommend to my patients is that they exercise as much as they can and slowly increase it as they can tolerate. Now, another thing that we really want to be cognizant of as physicians is that a lot of patients with fatigue are socially isolated, and it really compounds the fatigue, but support really helps. And there's a lot of great organizations, including the ALF and the PBCers, that may be a support system that's outside your homes. Now, itching or pruritus, this can occur in up to 20 to 70% of patients, and I've sort of divvied this up into non-prescription options and medication options. So non-prescription, some of the easy stuff, avoiding hot showers and hot baths, which really dry out the skin. People, particularly in Chicago, tend, it's cold outside, you want to come in and get warm. Cold packs can help. A lot of people in Chicago live in high rises, and high rises tend to have radiator heat. We tell patients to use humidifiers. And then Vaseline is a much better option. Oatmeal extracts are a much better option than things like Lubriderm. Antihistamines can be a useful adjunctive. They can be sedating, but those are often used early in itching. I threw liver transplant in here as a non-prescription option. It is a kind of a last option. It's really effective, but it's generally reserved for intractable itching. And we'll talk more about transplant a little bit later on. Now, medications, and these medications are as recommended in the EASL guidelines, the first line being the bile acid sequestrant. So these are drugs that are used for cholesterol, but they also bind bile acids. Cholestyramine is probably the most ubiquitous one. It's a powder. It tends to have a lot of GI side effects. And I'll use colesevelam, which is Welchol, which is a same type medication, but it's in a capsule form. It's a little bit easier to tolerate. It's very important that these sequestrants are taken 2 to 4 hours away from meds and meals because it can bind food and it can bind up medications. So that's a very important point to remember. Rifampin is second line. I will say in my practice, I like rifampin. Rifampin is actually an anti-TB drug. It seems to be well tolerated. You can get an occasional hepatotoxicity or liver test abnormalities. So it's something that can be managed. And usually I will check liver tests relatively frequently if I'm using rifampin, at least monthly. But I find that this is one that's well tolerated and pretty effective with itching. Other things, oral opiate antagonists, things like naltrexone and nalphamine seems to lower the itching sensation. There can be an opiate-like withdrawal reaction. And there's mixed data for using SSRI, sertraline, which is an antidepressant. You may have heard of Zoloft or gabapentin as a different medication. They have mixed data, but in some cases it can be helpful for itching. So Sicca complex is dry eye, dry mouth. We tend to tell patients to use artificial tears. If it's refractory, you want to send to the ophthalmologist. There are some things that can be used. Pilocarpine is a medication that helps lubricate for both dry eyes and dry mouth. Oral hygiene is very important to prevent dental caries and cavities. Consider referring to a dentist. Vaginal moisturizers if needed. For people who really have a lot of trouble with dry eyes and dry mouth, I tend to send patients to a rheumatologist to think about things like Sjogren's, which is dry eyes and dry mouth, but that's more of an autoimmune cause of dry eyes and dry mouth than just run-of-the-mill Sicca. So moving towards PBC complications. So osteoporosis is pretty common in PBC. We generally take a bone density scan every couple of years and encourage patients to be on calcium and vitamin D if they don't have kidney stones. For patients, and that's really preventative, for patients that have osteoporosis, things like bisphosphonates, alendronate is one that is commonly used. They're very effective. It can cause esophageal injury, so if patients have varices present, you may have to think about other options. There are a lot of other options for osteoporosis, and I will often refer to an endocrinologist as the options for treatment have really exploded in the last 10 years. Patients that have severe PBC and jaundice can actually have malabsorption of certain vitamins. So we tend to follow these vitamin levels every year and replace them as needed. People with PBC can also have hyperlipidemia or high cholesterol. The mix of cholesterol, though, is usually high HDL, which is a good cholesterol, and we don't usually see an increased cardiovascular risk for heart attacks and strokes. In patients that have cardiovascular risk, maybe they're overweight, hypertension, have poorly controlled diabetes, the cholesterol can be treated with routine statins, things like Zocor or Lipitor or Crestor, and they are safe these are safe medications in patients with PBC. So if patients do come to have cirrhosis from PBC, we want to look for things like varices. So varices are dilated veins in the esophagus and stomach, and this is really from portal hypertension. So what happens in a patient that has cirrhosis, the liver gets sort of scarred and a little bit hard, and the blood doesn't flow through it very well, and it kind of backs up into veins, in the stomach and in the esophagus, and those can cause bleeding, and it can be life-threatening. So patients that have cirrhosis, we'll often screen them with an upper endoscopy, which is a camera test. We look through the mouth into the stomach. And if we see those, we can put patients on beta blockers, which is a type of blood pressure medicine, or we can put rubber bands to prevent them from bleeding. We usually do this when platelets are less than 150. I left the less than 1 out. Or the liver stiffness measurement is over 20. Patients that have cirrhosis of any type are at higher risk for liver cancer, specifically hepatocellular carcinoma, which is primary liver cancer. And we usually screen for this with imaging every 6 months. There's lots of modalities to do this: ultrasound, CT, MR, and we'll often check blood work, specifically a biomarker, alpha fetoprotein or AFP, every 6 months with the imaging. So liver transplant for PBC, and I want to start this slide out saying the vast majority of patients with PBC will not need a liver transplant, particularly with urso and some of the other drugs we have with it. But we do want to consider liver transplant if a patient has decompensation, if they have varices that are bleeding, they have ascites, they have jaundice, really, really bad itching that is not really responding very well to medical therapy. They have an elevated MEL score, which is a score that that's based on some blood works, creatinine, bilirubin, INR, etc. The survival rate for people that need liver transplant is quite good, 5 years, 90%. Again, these are very ill patients when we get them. It is important that we want to see these patients earlier in their disease course and really get them transplanted before they become malnourished. Now, post-transplant, usually we'll see, up to about a third of patients will have recurrence of PBC. The good news is the functioning of the liver graft usually is not affected if it does recur. We use URSA pretty often to prevent recurrence. And cyclosporin, which is a type of immunosuppression medicine, may be a favorable way to keep the liver from rejecting and may be helpful to have less PBC recurrence. The good news is itching does improve after liver transplant. Fatigue, not always, but sometimes is better after a liver transplant. So I want to finish up here, and we should have a fair amount of time for questions. I want to talk about clinical trials. And so what else can we do for PBC? Now, PBC has what's called orphan drug designation for the FDA, and these are regulations that exist to encourage companies to develop therapy for rare diseases, and PBC falls under this rubric. U.S. requirements mean that it's less than 200,000 patients, and PBC easily qualifies. Europe has
We seem to have lost your sound, Doctor.
Can you hear me?
Okay, it's back. Yes.
Okay. Where did you lose me? How far do I need to back up?
Just the previous.
Here?
It was at the clinical trials.
Okay. So what can we do to, in the future for PBC? So PBC has orphan drug designation from the FDA, and what that really means is that the regulations are favorable to help companies want to invest money and invest resources in developing therapy for rare diseases. So PBC easily qualifies for that in the US. In Europe, this should say PBC, not FDA, but in Europe, PBC also has orphan status. And again, that helps us get clinical trials out for rare conditions like PBC. So I wanted to talk about a couple of clinical trials. The first one is from CymaBay, actually, and it's the RESPONSE trial. And this is a medication called seladelpar, and it's a PPAR delta agonist. And this is in what's called a phase 3 study. So this is an international study, which with well over 100 sites around the world. And this is set up similarly to previous trials like obeticholic acid, in that this is an add-on to patients who are partial responders to URSO or they're intolerant. And in smaller phase 2 trials, over half the patients enrolled reach the primary endpoint, which is less than the 1.67, so less than 200. So this is a big success, but also the itching in these studies seem to really improve. Now, this is a truncated entry criteria, but generally it's adults 18 to 75, men or women with PBC, and alkaline phosphatase greater than 200. If you're on URSO, you need to be on it for 12 months, and it needs to be the stable dose for the previous 3. People who are off URSO for whatever reason are allowed, but they need to be off of it for 3 months. The bilirubin needs to be less than 2. And unfortunately, right now, there's no cirrhosis, advanced cirrhosis enrolled in this trial. Also, patients need to be off obeticholic acid and fibrates for 3 months. So if you're interested, or if anyone's interested, there can be a washout in enrollment into a trial. Now, there's another PPAR drug. This one's less specific. It's an alpha and delta agonist. It's also an add-on to URSO partial responders or non-responders. And it's also an international study. The entry criteria are fairly similar. I do want to highlight in both seladelpar here, I did include the website for patients to get more information, www.pbcstudies.com. And this is the NIH websites where all clinical trials are listed. I've done similar here for the elfibranor. This is the pbcclinicalstudy.com, as well as the clinicaltrials.gov again. I've listed here some other resources. Many of you are familiar with the ALF. There is a PBC-specific organization called the PBCers that has some good information on it. And I do want to draw your attention to the clinical trials website. This is sponsored by the National Institutes of Health at NIH. So any clinical trial available for any disease is listed here. It is searchable by PBC. It's searchable by close to where you live. And there are a lot of trials in there for PBC. There's some for patients with PBC and itching. I've just sort of picked out the 2 main ones that I think are most relevant for most patients at this time. I do want to draw your attention, most of this information comes from guidelines, either from the American Association for Study of Liver Disease or from the European counterpart, and I've listed I've listed the actual where I got the data from, and there's some other data slides that I added up already. So in summary, PBC is an autoimmune or inflammatory condition of the bile ducts that requires lifelong care. URSO is effective at decreasing long-term complications. PBC symptoms are manageable. Other treatments for PBC exist, but there remains an unmet need for better treatments, and clinical trials are ongoing. And if any of you wish to contact me, I've listed my my email address there. And Warren, I think that's all I have for right now.
Great. Well, boy, I have pages of notes here, so I can imagine how your students in class get the information from you. So yeah, so thank you very much for that. You touched upon really a lot of the areas of the questions that were received, but there are still a few questions, so we do have time. So I will erase them. I want to begin by saying too that so this presentation is being recorded, and as pretty much all of the ALF programs, it will be posted on our website. If you go to the disease section PBC, as well as in our YouTube channel, the American Liver Foundation YouTube channel. It will be posted there. And we do have a very, I guess, vibrant is okay to say. If we have very vibrant PBC Facebook page. If you're not a member of that, we certainly encourage you to join that so that you will be able to go back and to see this information once again. So I just want to begin by saying that in case we don't get to maybe repeat something the doctor said or a question. So the first one, doctor, just I guess it is so obvious, PBC and COVID. With COVID, the disease itself, COVID with the vaccines, URSO and vaccines. What's your overall comments on just that whole situation, PBC and COVID?
Well, I think, this is sort of generic advice for anyone with a liver condition. I think it's important that patients are vaccinated, and I would encourage, boosting as well, 6 months after your vaccination is complete. Patients who are immunosuppressed may actually be considered for a fourth shot. That's somewhat a little controversial. I know we're doing that in the IBD world, of Crohn's disease and ulcerative colitis, and certainly in our transplant population, we're doing the same. But I do think that's worth discussing with your personal physician. Again, I'm a huge advocate for vaccinations, as many physicians are, and I do encourage you to get a booster if you qualify.
Great. Okay. So another question. We'll stay to the topic of the URSO. Are there any? Because most folks will have comorbidities, meaning they'll have other challenges. I guess pharmacists and doctors know if one medication is going to interfere with another. So offhand, do you have any ideas of what, if somebody's taking URSO, what they should be careful of, or what may not, if somebody has osteoporosis, may be taking some medications for that? Is there something that our folks should be aware of with the interactions?
Yeah, URSO is usually pretty well tolerated, and it's usually goes well with other it usually plays well with other medications. I think there may be some specific one-offs. I did mention that cholestyramine, which is used for itching, it's one that can interfere with drug absorption of other medications, and that should be dosed, 2 to 4 hours from other medications. There may be some very specific things that I'm not aware of, but in general, I don't tell patients to take their URSO separately from anything else.
Thanks. So in terms of PBC genetically, is this something that's passed on through family? So if a family member has PBC, should other family members be tested, or should they be conscious of this moving ahead? What for somebody, so for a person who has this, and you're concerned now are your family members, what approach should people take in that regard?
Yeah, so it's a great question, and one that I think, what I tell patients in my clinic is that, you can check, in your first degree relatives, you can check an AMA, and if it's positive, that's something that you can watch over time by checking liver tests. I think that's a reasonable option. Some people, they just don't want to know, and they, if the liver tests are, you may tell them, well, tell your loved ones your liver test to get them checked periodically. If they're elevated, then they should see someone. It's not a standard recommendation like we do for other genetic things like hemochromatosis, where we recommend that patients get their family members tested.
Great. And also earlier on, you did mention that even if somebody tests positive with AMA, doesn't automatically mean a PBC diagnosis as well.
That's right. Positive AMA does not mean PBC. It just means that they may develop it, but it's something you can check yearly, and I wouldn't sweat it. And
that's the monitoring of it. Okay. Can there be a regression of PBC? So if somebody has this diagnosed at a higher level, is there such a thing as a regression of it?
Yes. I mean, I think you can go to a higher state. And I was just looking at this question. It's a good question. You can go from a higher stage to a lower stage. We don't routinely biopsy. You have to biopsy to get staging. We do have some less invasive ways of looking at liver stiffness, both with FibroScan or MR elastography, which is becoming more available across the country. And you may see fibrosis scores or liver stiffness scores improve, and that may be evidence of regression. This blood test, this ELF test, which is a combination of 3 different blood markers. We may see that as a good way to follow people over time. But yes, the answer is yes, it can regress.
I didn't catch, someone asked a question about the gene therapy for the future. Is that something that clinical trials are looking at, or do you, in your own professional opinion, think that may be something?
I think it may be something in the distant future. I haven't heard anything specifically about gene therapy treatment. That's not to say that there isn't something. I just looked at the clinical trials website and didn't see anything listed as an active trial, but I'm sure someone might be thinking about it.
Right. Okay. You mentioned biopsy. What does a biopsy? I know that there's a hesitancy. I shouldn't say hesitancy. Maybe it's usually something that's put off for a little bit of time, because anything invasive, right, is always, it carries risks and things like that. But what would a biopsy show, or what would it not show?
Well, I think a biopsy really is when we're unsure of the diagnosis of PBC, or we want to see if there's a concomitant disease like autoimmune hepatitis or NASH, for example. In which cases, I think it might change my management. Or I'm not sure if it's PBC. Could it be sarcoidosis, which is a completely different disease? Are you worried about a lymphoma? But there's usually other things that are muddying up the picture of a standard PBC patient. I will say that probably 85% of my patients or higher don't get a biopsy in standard practice.
I know here in New York, there was a news story about full body MRIs, and the pros and cons of that. And I think most of the medical people were cons, because it could show anything. And are you scaring yourself, or are you seeing something there that's maybe not necessarily going to affect your health? And so I guess there's perhaps it's the same thing with the biopsy, in that a lot of testing sometimes is not so great either, I guess we would say.
Right. I mean, I think the important thing is that if a biopsy is going to change your management, that's a discussion you should have with the patient. And it should be shared decision making.
Right. And a big question in various forms that comes in. I know you're not necessarily, I should say, a nutritionist or a dietitian, but obviously with any liver disease, we know that diet is hugely important. And so in regard, what would be just some of your general comments to your own patients when you talk about their diet? What should it be? What should they avoid? What should they add? Just general. And again, I know there's a lot of specifics we could get into.
Sure.
What kind of salad dressing should I have? So what could you say? Because that's something that people each day at home, we tell people that, your nutrition is your treatment. And and it's something they have control over. So what are just some of your comments about that?
So, I think diet, it's one of those things where, particularly if you have a disease with it like NASH, which is really a nutrition associated disease from generally eating too much or the wrong types of certain foods, a lot of carbohydrates, a lot of fattier foods. I think you want to sort of treat the NASH because that's going to make your overall liver disease worse. Mm-hmm. If you're drinking too much alcohol, and I would say that, for women, we say sort of 7 drinks a week, but not more than 4 drinks certainly never more than 4 in a day. And you shouldn't binge. I might caution them to go to 3 to 4 drinks a week. I think smoking is something that should be avoided. I think in general for diet, just a well-rounded diet with lots of fruits and vegetables, less processed food, plenty of exercise, just sort of good common sense things. I don't think there is a PBC specific diet. The only caveat to that is someone who has cirrhosis, and particularly if they're more malnourished, you don't want to skimp on protein, and protein is a really important thing.
Yeah, I know the Mediterranean diet in a lot of ways is discussed with liver disease because it's natural. It's, well, as we say, fresh food, clean food. That's what we offer to people who have cirrhosis or even fatty liver, before it, so that it doesn't progress. So no doubt a lot of those guidelines would be the same for the PBC community as well. Yeah,
I think that's
yeah.
good for pretty much almost everybody, right? Just sort of Mediterranean diet. I mean, that's the easy answer.
Right. Yes, that's right. Yeah. And we tell people, if you're eating that way, make sure your family eats with you, because you're going to keep them healthy as well. Right. And and also supplements, right? You did mention some vitamins, things like that, but we always caution people and tell them a supplement is just what the word implies. Right. So it's something that, because we saw a nice ad for certain vitamins, or, we see something on TV, that supplements should only be used to supplement something that maybe our body's not absorbing. And so I believe seeing a dietitian or somebody along those lines who can really evaluate what are a person's vitamin supplement needs, and then do it, right? It's not just a supplement shouldn't be just something you just go to the drugstore and buy it because the label said it's good for you.
Yeah, I'm glad you brought that, but I'm going to get up on my soapbox for just a minute here about supplements. And in general, I'm not sort of anti-control. I mean, I want people to have full control of their life, but there are a lot of things out there that are sold as liver regeneration formulas, or those types of things, particularly have a lot of ingredients. I tell all of my patients to stay away from those. They often will have some drugs like black cohosh or things like green tea extract, which are actually known to cause drug-induced liver injury. So I'd be really careful about that. Things like silymarin and milk thistle have been looked at in PBC without really improving anything. I suppose if it's pure milk thistle, you may be okay to take it. I just don't know that it's helping you, and there's data saying that it doesn't.
Okay. Yeah, that's milk thistle. We get a lot of calls in that regard. Well, Doctor, we're at our time now. The one other thing I want to mention was, when you were talking about fatigue, there was a study that I attended a seminar recently, and it talked about mindfulness and meditation. Yep. And for not side effects, but for the effects of certain diseases, of course we look at medications, things like that. But there's definitely those holistic things as well. And I believe it was over here at Mount Sinai in New York, where there was and it was PBC patients. It was a group of PBC patients who were put through, I think, like an 8-week program of mindfulness. And then they continued it for 3 months later. And it was really a statistically significant decrease in the amount of fatigue that people felt. So we talk about exercise, things like that, but these holistic approaches can be very helpful as well.
Yeah, I didn't get into that, and perhaps I should have mentioned it. I've talked to I've had patients that got trained to do transcendental meditation. I have a lot of patients that do yoga. I think mindfulness is something that there is a lot of interest in looking at. It's a little hard to prescribe mindfulness right now, but I know there's a lot of interest in looking at it. But I think any structured mindfulness training program is probably a good idea to try. I think it's low risk, and it may have quite a bit of improvement in patient symptoms. So I would encourage that.
Yeah.
And I have a few minutes if you need to go longer. I know we got started a little bit late.
Oh, okay. So let's just see. We did have one question about medical marijuana. We hear this in people asking about some other aspects of liver disease. My guess is going to be still under studies going on. What would you say in regard to that?
Yeah, I think medical, I mean, and I get this, multiple times a week. And in general, I'm anti-smoking marijuana because I think there's other toxins, but I think some of the edibles may have, benefit. The question is which one, and it's a little hard to tell. Marijuana is now legal here in Chicago, and if you walk into a marijuana dispensary, there are a lot of different things and a lot of different products out there. It's just hard to prescribe it. I don't know what to prescribe, and what is it you're prescribing for? Is it more anxiety? I don't know that medical marijuana itself is going to help PBC, but things like anxiety and depression, or anxiety, it may be helpful for. It's not an area that's really been studied in liver disease. And perhaps smoking it is okay. I don't know. I don't think we know enough yet to make a determination one way or the other. And again, I'm not anti marijuana. I just, I'm still not comfortable around the concept of smoking anything versus an edible.
Right. Boy, so many studies, and I'm going to guess if we came back here and on January 24th of 2023, there will be further developments in the area of medicine in general, but certainly in PBC. And so we're always watching the research, and of course yourself as a teacher, who's guiding future hepatologists and gastros. That research is so important, and so we really do appreciate your bringing that research to us in this presentation.
Okay.
All right. So, well, once again, we want to thank Dr. Reddy for being with us today and for sharing all this information. So, Doctor, on behalf of all of us at ALF and those attending this program, as well as those who are going to be viewing this online, we want to thank you for the points that you brought up. And as a few comments said, that this was one of the more informative of these programs that folks have heard. And so we're grateful to you for that. If you'd like more information on PBC and other liver disease and liver wellness, you can always go to our website, which is the www.liverfoundation.org. Check out our YouTube channel, where we do have more informative programs. And as the doctor showed us in that presentation, isolating yourself can lead to fatigue and some other things. And so be social. And as I mentioned, we have a long-running PBC Facebook group that anybody with PBC, their caregivers, family members could join. And we're in this virtual world now still, unfortunately, so a lot of in-person groups are not meeting, but certainly that PBC Facebook group, the group PBCers, also offers support. So please look into those so that you're not isolating. Disease not only has that physical effect on us, but there's an entire emotional element to disease. And one of the ways to try to allay some of that is to be social, to be with others, to talk it out. And so that's why support is so important for that. Okay, and so finally, we're once again thanking our sponsors, CymaBay Therapeutics and Intercept Pharmaceuticals, for always assisting the ALF in our programming. So thank you all once again, and we'll see you next time when we have a brand new episode of the ALF Ask the Expert series. So, Doctor, once again, thank you, and